Hi, I'm Dr. Mark Greenstein with Advanced Urology, and this is a discussion about elevated PSA. So PSA stands for prostate-specific antigen. It is a protein made in your prostate. Its only job that we know of is to help break down and provide nutrients for sperm so that you can have a child. After that, the protein really is just a marker so that we can tell if there's something wrong with the prostate. As life goes on, PSAs go up. As life goes on, PSAs go down. There are numerous things that can cause a PSA to go up, and that's what brings people to our office. These include infections, prostate enlargement, genetics, and of course we worry about prostate cancer. So when a man is referred to a urologist for elevated PSA, there's a few things that we're going to do in the office. Obviously, we're going to do a history and physical. We are going to check your urine. A lot of times we will check the residual left over in your bladder to see if that has something to do with why you're in the office. And during the physical exam, we're going to do a digital rectal exam, the DRE. This is where we examine the prostate to feel for masses of the prostate. Now, just because you have an elevated PSA does not mean that it is a doomsday. You know, you're going to go on the internet, WebMD, Google MD, they're all going to tell you bad things are going to happen, but that's not true. But certainly if there's an elevated PSA, there are a lot of things that we're going to consider. There's something called PSA velocity. What's the change of your PSA over time? Is it going up? Is it going up quickly? Is it staying flat? Another very important marker is called PSA density. And that's basically what is the PSA divided by the size of the prostate. So in other words, let's pretend you have a person with a PSA of 5, and everyone's like, ooh, 5, that's bad. But what if the person has a 100 cubic centimeter prostate? That's a low PSA density. That PSA elevation is probably due to enlargement. Very different than a person who has a PSA of 5, and they have a prostate volume of about 25 cubic centimeters. That is a very high PSA density, and that's someone that I'm going to worry about. Now, if someone is having this elevated PSA, there are things we can also check. One is called a 4K score. A 4K score is a separate blood test. I do it on separate days of the exam. So we examine you, we talk, and then if I think you need a 4K score, we're going to have you come back, draw your blood, you just leave, and in about 7 to 10 days later, I'm going to get a result. A 4K score looks at percent free PSA, total PSA, and a hormone called kallikrein, which is run by this company called OPKO, and I'm going to get a percent risk that comes back in the report. In other words, what's the percentage risk that you have a high-grade prostate cancer right now? And I'll get an answer, 2%, 25%, 60%. Anything greater than 7.5% is a red flag, and we're going to want to consider moving on to a biopsy for that person. Another thing is called SelectMDx. This is a biomarker test. So this is where you come in. We actually have to do a prostate massage. That's where I do an exam. We do the DRE and actually push on your prostate to express fluid from your prostate into the urethra, and then the man urinates afterwards into this little kit, and the fluid goes off to the lab. And it's going to tell me, is there any risk with these biomarkers that a person is developing prostate cancer? And I'll get a result that says low risk, high risk, medium risk, etc. And obviously if there's any risk involved, then we're going to want to move on to a prostate biopsy. Some men need an MRI. MRIs, they're getting better and better every year. The technology is getting better and better every year. And it can pick up these little growths of the prostate that we may not be able to feel when we do an exam. I tend to reserve the MRI for the men who have had a previous prostate biopsy. It was negative, but their PSAs are still going up. Now, there are some men that will get a PSA up front if their PSA is elevated, but that's on a case-to-case basis. Now, the only way to know if you have prostate cancer is to do a prostate biopsy. That's the only way. Everything else is just getting more data. A prostate biopsy is done in two fashions. There's two ways of doing it. One is in my office. You come in, we usually give you a little bit of Valium to take the edge off. We give you a dose of an antibiotic in the tush, so we give you an intramuscular antibiotic injection. You have to do a fleet enema before you come to the office. And then after a little bit, after the antibiotics kick in and the Valium has made you a little quiet, you're going to lay down on your side. An ultrasound's going to go in the backside. I look at your prostate, I measure your prostate, and then I numb the prostate. Then we do the biopsy. Standard of care is 12 cores, 6 on the left, 6 on the right. The whole thing takes me 10 minutes. I look to see if there's any blemishes of the prostate. Is there a growth? Is there something there? And then you go home and take it easy. The other way is to do it in the surgery center. The surgery center is for guys that need to be sedated for the biopsy, and the sedation is just like having a colonoscopy. So you come in, you have to do the fleet enema at home. You come in, we put an IV in the hand, we give you a big blast of antibiotics in the veins. You go back to the procedure room, and you're knocked out just like a colonoscopy. And then the same thing happens. Ultrasound goes in, I measure the prostate, I numb the prostate, and then I take the biopsies. The whole thing takes me 10 minutes again. Sometimes I'll look inside the bladder at the same time, specifically if a person has lower urinary tract symptoms like frequency, urgency, things like that. Or if they do have some microscopic blood in the urine, we'll want to take a look inside the bladder. You go to the recovery room at this point, you wake up, you get a snack, you go home. Now, the biggest risk of a prostate biopsy is me giving you an infection because I'm sticking needles where they don't belong. The risk of infection is anywhere from 2 to 5% depending on the individual and their overall health. And the person will know that they're getting an infection because a day or 2 or 3 after the biopsy, they'll call us up saying, "Holy cow, I don't feel good. I got a fever, I've got chills, and it's burning to urinate." Well, I gave you an infection, and unfortunately it happens. If that happens, we give you extra antibiotics, and 95% of the time the person's great. Every once in a blue moon, I have to put someone in the hospital for a bad fever. The other thing that can happen from a biopsy is bleeding. Once again, I'm poking holes where they don't belong. And so you can see some blood in the urine, you can see some blood when you move your bowels, and if you have intercourse anytime after the biopsy, you may see some blood in the ejaculation. It all goes away. The bleeding is almost never a problem. The person then comes back to the office a week later and we talk. Are we going to talk about bad things like prostate cancer treatment? Or are we going to talk about other things like prostate cancer prevention or treatment of inflammation or treatment of prostate cancer enlargement? But that's basically the gist of an elevated PSA. It's a talk that I give very commonly during the week, and so I thought it would be best to get it on the internet. So if anyone has any questions, they can always go right back to this video. Please let us know.